Moving. Right. Good morning once again, everyone, and welcome to the Town Hall on Data and Research Needs to address racial health disparities in the COVID-19 crisis and beyond. My name is Kelsey Berkfeld. I'm the Coalition Manager of Advocates for Ohio's Future. We are a nonprofit, nonpartisan coalition of 500 health and human service policy, advocacy, and provider organizations. I'm pleased to welcome the members of the Data and Research Subcommittee of the Minority Health Strike Force and over 100 registered participants of today's meeting. In an effort to ensure that the public has access to the meeting, please know that we will be recording and posting to our website immediately following the conclusion of today's meeting. All the participants will be in listen-only mode, and the presenters should stay muted until it is their turn to speak and answer questions. Members of the Data and Research Subcommittee are welcome to answer questions. We will also be taking members from participants through the chat box if there is time. This is the second installment in a series of town hall meetings hosted by Advocates for Ohio's Future, the Children's Defense Fund Ohio, and Policy Matters Ohio. We're focused on giving stakeholders an opportunity to engage the subcommittee members of the Minority Health Strike Force. Ohio Governor Mike DeWine convened the strike force to address racial health disparities that were heightened due to the COVID-19 pandemic. For today's meeting, I will serve as the moderator, and I will go ahead and hand it over to Mr. Steve Wagner. He is the Executive Director of the Universal Healthcare Action Network Ohio, also a co-chair of Advocates for Ohio's Future. Take it away, Steve.
Thanks, I forgot to mute myself at first. So AOF is holding these town halls because it believes that policy is best informed by many voices, especially by those voices that are impacted by inequity. So today we are primarily hearing about data and research to fit within the focus of one of the strike force subcommittees. As listed in the interim report, the Data and Research Subcommittee has a mission to provide recommendations that improve statewide COVID-19 response and recovery efforts for vulnerable populations, including people of color, and that includes identifying solutions to overcome gaps in data which negatively influence statewide disaster response and recovery efforts and exacerbate existing health inequities, creating ongoing opportunities that document data-driven decisions to effectively respond to health inequities and improve health outcomes related to COVID-19, documenting the formulation of data-driven policies to improve clinical management and health outcomes, and to guide equity. So in the short time frame, AOF and its partners work to create spaces where the strike force could hear from other voices, and in doing so, make better informed recommendations. All of the information provided today, as you heard from Kelsey, will be afforded the strike force. AOF submitted its own recommendations to the strike force members yesterday. The report from the strike force will be the beginning. It will require unrelenting action, advocacy, and dialogue. 400 years of inequity and oppression will not change without all of us committing our hearts and minds to positive, lasting change. We're really deeply appreciative of all those who have been able to join us today and provide their thoughts and input so that I think in the end, we hope that the strike force will have better informed recommendations, and then we can all move forward to really see positive change occur. So with that, am I going to turn it over to the first speaker? And Kelsey, do you see the slide that says public testimony? That you're muted, Kelsey.
Thanks, Steve. We are actually going to move forward. Jody is having some issues logging on. So if you wouldn't mind advancing the slides to Kelly Grisner's presentation. Kelly, you are up. Thank you so much for joining us today. And a reminder to our presenters, there's a 5-minute presentation window that we're asking you to keep to. Daryl Johnson will be giving you a nudge at the 4-minute mark and at the 5-minute mark of your remarks. So Kelly, whenever you're ready, please move forward with your presentation. Thank you.
All right. Good morning, and thank you for including me. At the Women's Fund of Central Ohio, I'm the president and CEO, and we are focused in transforming the lives of women and girls. And so our focus on health, and especially the health of women of color in our community, intersects, what we're looking at is the intersection of economic empowerment, how health is affected by that, and certainly because both of those things are going to prevent women's leadership in our community, which is ultimately what we want. So as we move to the next slide, what I would say is that we did back in April of last year, we released a wealth gap report. This first slide shows nationally what women earn, pay only. And you can see here that obviously women of color, Black women earn 64 cents nationally, Latina women earn 55 cents nationally on average compared to white men. But the next slide is actually Ohio's stats, which show that it's very similar numbers. But what became important to us was not just focusing on pay, but focusing on wealth. And that's where this is really the cusp of our research. When you look at these stats, they're staggering. It tells you that women of color make only pennies, own only pennies on the dollar when compared to a single white man. And our numbers national in Central Ohio are the same as these national numbers. So we use as sort of our bedrock this point that a single Black woman owns 2 cents to the dollar when it compared to a white male. And when we think about then what either accelerates or decelerates her ability to change that situation, health is a very important part of that. Because obviously a healthy person, a person who can work, who can take care of their family, is able to earn wealth, not just pay, but wealth, is able to save, is able to be safe. When someone doesn't have wealth, health is a major decelerator because number one, if you don't have any wealth, you likely don't have good health care. You don't have the ability that if you become ill, you can seek the services that you need to get better. You have no safety net whatsoever. And so we know that health is one of the most major and insidious decelerators of women's ability to work out of poverty, because not only do they have to take care of their own health, very often they're also taking care of the health of all of their family members. So if we look at the next slide, what we started trying to look at were these barriers, these accelerators and decelerators. And what we have to realize is that there is a web of things that many people think are actually accelerators that can very quickly become a decelerator to a woman's wealth. For instance, very many people would encourage people to go to school and take out student loans in order to work their way out of poverty. Well, those student loans are quite often one of the first things that then holds a woman back. She's gonna not, if she's has student debt, she's not gonna get the health care that she needs, or she's not going to splurge, if you will, on the health care that she needs. And this is what women of color, and specifically Black women, Latino women in our community are facing as single mothers. Because the next thing that we know is that 35% of the cost of wealth bearer comes with the children that they're taking care of. They are in very high numbers. Nearly half of the families living in poverty are led by single mothers. And then the health of themselves and their children are part of their puzzle. And then the other things are some of the things that are becoming most poignant during the COVID-19 job loss. They were already working in some of the most essential jobs, and yet some of the least valued jobs, making the least wages, or the first jobs to be cut if they aren't essential. So going on to the next slide, some of the findings that we had with our wealth gap report before COVID was, as I said, 15% of women live in poverty, only 11% of men do. Almost half, 45% of these households are living below the poverty line, have single women at the head of those families. And their health is definitely influenced by their wealth. 15% of these women have significant health issues the past year, and have had a recent, 31% of them have had a recent health issue for themselves or their families. And they are also facing debt because of that health issue. Definitely, again, a decelerator to them working out of poverty. And certainly when they're unhealthy, that's something that's the most difficult thing to overcome. We know that home ownership can also be an accelerator or decelerator. Quite often people encourage women to go out and buy a home, but they have some of the most predatory mortgages and are the least likely to get any kind of assistance when they're trying to work out of that situation. Caregiving is never equally distributed, and we've seen that no more than we see now in this COVID situation. And education, again, as we discussed, can also be as much of an obstacle as an accelerator if there is debt attached to that. So moving on, this is how women on the front lines, our look on the front lines in this situation. And the one thing I would say is that if we want to, 5 minutes goes fast. If I would just go to the next slide so you can briefly see the COVID and the COVID situation, 55% of the job losses were held by women, yet 52% of women are essential workers. So they are in a very difficult situation, and their health is a major factor that we must consider.
Thank you so much. Any questions for Kelly from Strike Force members? Please feel free to unmute yourself. Great, thank you so much. And as questions continue, if you have questions, please again submit them to the chat box, and then Kelly, we might come back to you to answer a question later on in today's presentation. So thank you again, Kelly. Our next presenter will be Marie Curie. She is the managing attorney with the Community Legal Aid Services, and today she is representing the Ohio Consumers Health Coverage. Marie, whenever you're ready.
Thanks. Is my sound coming through?
Yes.
Wonderful. Good morning. My name is Marie Curry, and I'm speaking to you this morning on behalf of the Ohio Consumers for Health Coverage. First, I'd like to thank the organizers of the Town Hall Advocates for Ohio's Future, Policy Matters Ohio, and Children's Defense Fund Ohio for bringing us together to identify opportunities to improve the health of Ohioans who are disparately impacted by COVID-19. I'd also like to thank the members of the Minority Health Strike Force for attending this morning and being open to the input that I and the other presenters have to offer. Next slide, Steve. I'm the co-chair of Ohio Consumers for Health Coverage, a coalition that brings the consumer voice to policymakers with the goal of achieving affordable, high-quality healthcare for all Ohioans. OCHC is comprised of more than 20 organizations that represent Ohioans in all their diversity. Go ahead, Steve. We are guided in our work by 5 core principles, which are described on this slide. The only one I'm going to read is the last one, that healthcare outcomes should not be predictable by race, class, gender identity, geography, language, or other social factors. That principle is at the center of what we're discussing today. Go ahead, Steve. My purpose for presenting today is to emphasize the need for visibility and transparency in the efforts that we make to reduce racial health disparities that we see in Ohio. In order to deconstruct institutional racism in the systems that we rely on, we have to intentionally ask, what do Black and other minority Ohioans need? We have to make visible something that has been allowed to be invisible. We have to look at every facet of these systems and ask, what is the impact on health? And is there a difference in the impact on health if we examine the data by race and ethnicity? And if there is a difference, why is there a difference? And are the interventions that we are implementing sufficient to address that difference? Go ahead, Steve. When we ask those questions, in order to answer them, we have to have the data available, disaggregated by race and ethnicity. We cannot answer these questions if we don't collect the data in at least that level of detail. We're talking about data on medical, social, and behavioral factors. Ohio's running a natural experiment right now by the actions it's taking in response to this public health emergency. The opportunity to gather the information we need is here right now. If we collect data on the impact of reducing and eliminating copays and premiums on the use of healthcare, if we collect data on the use of telehealth, if we collect data on the treatment for mental health and substance use disorders, and on people's experiences, and on all the testing, whether the results are positive or negative, and on our contact tracing initiatives, if we collect data on the use of community health workers and peer support services that we use to reach our Black and other minority Ohioans, if we collect this data by race and ethnicity now, as we're putting in place the interventions in an effort to give Ohioans the tools they need to be healthy during this public health emergency, we will have a wealth of information to examine to better understand what helps our Black and brown neighbors, co-workers, friends, and family not only survive, but thrive. Go ahead, Steve. Furthermore, if we want to achieve health equity, we need to establish equity metrics and then create the environment where our healthcare providers and our managed care organizations strive to meet benchmarks by race and ethnicity. Go ahead, Steve. Ohio Consumers for Health Coverage has been working for the last several years to obtain and analyze Ohio Medicaid data to better understand factors that define Ohio's racial health disparities. We understand the need for better data to be able to improve health outcomes for Black and brown Ohioans. We are encouraged by the formation of the Minority Health Strike Force and the inclusion of Data and Research as one of the 3 subcommittees. The concepts I presented in these few minutes are high level, but the opportunity exists to make them concrete. Thank you for allowing me these few minutes to share OCAC's convictions about the importance of what the strike force is seeking to accomplish, and thank you for your time.
Thank you so much, Marie. Any questions from strike force members? All right, sounds like we are absorbing our information this morning. Thanks again, Marie. We might have a question for you later on, so thank you so much. So moving to the next presenter, we will be joined by Janelle Denizen, supported by Josh Johnson from Ohio. Janelle, whenever you're ready.
Thank you. Josh, are you on?
I am, yes.
Cool. Did you want to go ahead and give that
Yeah, well, again, I'm Josh Johnson. I'm the Training and Technical Assistance Coordinator. I'm here supporting Janelle Denizen. Denizen. And first, I wanted to say thank you all for creating this forum for us to share the work that's happening, in Ohio, but also around the state, specifically around creating racial equity within the homeless system. I'm a part of our Racial Equity Committee at Ohio, and also part of the Ohio statewide Homeless Racial Equity Committee. Ohio, if you can go to the next slide, please. Ohio is a coalition of organizations and individuals committed to ending homelessness and promoting decent, safe, and affordable housing for all, with a focus on assisting low-income Ohioans and other special need populations. I'm sorry, go back to that slide, please. So Ohio has multiple programs throughout. I'm not going to name them all. They're there. So we've created a racial equity committee that from all sectors of our program that talks about how to increase equity within the system. Now, this conversation started about 2 years ago when we looked at our numbers, and consistently African Americans made up close to 49% of the homeless system, even though only representing 12% of the Ohio population. And we know that homelessness has a negative impact on both physical and mental health of folks who are going through these systems. And we also recognize that this is a direct result of 400 years of historical and contemporary, racist policies and practices. So we developed a multi-pronged approach to kind of address this. And one of that is analyzing data. And that's kind of what Janelle is going to talk about today, is just how they've created systems to look at the COVID-19 response within the balanced state continuum of care. And Janelle, go ahead.
Thanks, Josh. Actually, you can keep it on that slide just a minute longer. Well, not a whole minute, but so that the HMIS bubble there at the bottom is the one that I work for. I'm the data analyst. And that's I'm the HMIS data analyst for the Ohio Balance of State COC. So I'm sorry if I'm saying stuff that you already know, but a long time ago, HUD divvied up the US into what's called continuums of care, which is COC. And Ohio got divided into 9 pieces. 8 of those are each counties with larger cities in them. And the Balance of State COC is just the nicer way of saying the rest of the state. So you can go to the next slide, finally, thanks. So like I said, the Ohio Balance of State COC is the 80 of the 88 counties in Ohio. So on this, this top icon here is the blue area of Ohio. So everything I'm talking about going forward, I just want to be real clear that it's about those areas and not the counties that are colored in white. Our COC has a coordinated entry system, and we have access points that prioritize people for housing who present to the system. So you can go to the next slide. This is the team that I worked with to develop our COVID-19 data collection strategy. Next. These are the sort of the decision points that we had to make in creating this workflow and how to collect the COVID-19 data. The one that I was very, anyway, next. I have 1 minute left, so I'm just gonna try to get to the very main points here. Next. So with this data, we wanted to start with what reporting we wanted out of it. One thing that we wanted, the main thing that I'm working on right now is adding a column to our prioritization report. And that report helps inform prioritization meetings that go on all over our geography as to how to immediately house people who are literally homeless. And so adding this column about COVID-19, the COVID-19 status of a household is very important to us, and we need to do it right. I've been working with an epidemiologist named Angie Hetrick to help me with the logic to decide. If you can go to the next slide. This is the intake form that our case managers use. You see there's a lot of yes, no data, there's a lot of dates. But anyway, we want to use this data to decide which households need immediate non-congregate housing and which ones are at risk, and these kinds of things. So next. This is the prioritization report I was referring to. I had to squish out some stuff that might be personally identifying. That's why there's like paint on it and stuff. But this column over to the right is the column that I'm trying to add. Thank you for the mouse action there. So that is what we're trying to do next. And so the other reporting pieces that we wanted to do is some like COC wide data, just looking at what the symptoms and may have COVID-19 according to the CDC, or if someone was positive. And along the x-axis here, you can see these are the dates that people were assessed. So we're just looking at things internally to see what this data is giving us. Next. Oh, I'm 1 minute over, I'm sorry. This has to do with the prioritization report column, and I will hand it over to you all.
Thanks, Jody and Josh. Do we have any questions from our strike force members on the data being collected by Ohio?
Kelsey, Dr. Dawson, I don't know if you saw in the chat, she had a question or a comment earlier, but was muted. So I don't know if someone can unmute her.
Yes, Director Dawson, you are unmuted and ready to go. If you'd like to.
Thank you so much. So this was for Ms. Curry, who presented, and certainly I'm speaking as the director of the Commission on Minority Health. And since our inception in 1987, we have focused on the importance of the collection and public reporting of disaggregated data by race, ethnicity, and primary language. Ms. Curry, can you speak to the importance of strategies like health equity and all policies as a means to codify the collection of this data?
Yes, absolutely. Thank you for your question, Commissioner Dawson. The concept and the goal of a health and equity in all policies approach to policymaking is to understand and recognize, actually, as our governor has said several times from the podium on his at his press conferences, that there are many, many aspects of our structures that impact health. Our transportation system impacts health. Our zoning system impacts health. The rules that we have for licensing professionally and for drivers all impact health. All of these systems impact health. And when we make changes to them or create them, if we want to understand how they're going to impact health, and in particular, if we want to look at them as tools to reduce racial health disparities or other health disparities, we have to consider that prism when we're creating them, when we're changing them, when we're identifying and potentially making shifts. We have to use that prism of health and that prism of equity to say, how is it impacting health and who is it impacting in different ways? And if we do that, then we have the opportunity to think, well, is this really the best way to do this? Is there another way to do this? Are we targeting our interventions or our changes in a way that's going to improve the life of Ohioans the way we hope to improve the life of Ohioans whenever we're making policy? So that's the basic framework. And we do have right now an effort to bring this view and this way of looking at policy to Ohio in a more structured way. And I'm not at liberty to have a conversation about that because I'm not permitted to speak about pending legislation. So I will leave it at that and let the commissioner or someone else perhaps pick up the baton from there. The mantle, maybe I should say. I was thinking of a running baton, just to be clear.
Just one quick follow-up. Can you talk about the importance of the role a overarching health equity plan for the state of Ohio could play in the achievement of the disaggregation of data and the collection of that, and ultimately the improvement of health outcomes and life expectancy?
Absolutely. We have we are wonderful in Ohio. We have 88 counties that do all kinds of great things. But if we had a coordinated, structured way to make sure that we're collecting this data, to make sure that we're feeding into a database that would capture what we're trying to capture. One of the frustrating things about watching the COVID-19 data, particularly at the very beginning, was that big long bar of unknown race. We don't need to have that. We can capture that data if we decide that that's important. And if we create a statewide framework, then we have the opportunity to really be able to look at things in a comprehensive way, to identify where we can focus our resources and how, as a state, we can improve our health outcomes. I'm not sure, Dr. Dawson, if I hit all of the pieces that you were mentioning, so please bring me back around if I missed something.
Thank you, you did.
Thank you, Director Dawson. Thank you, Marie. Any questions before we move on to our next speaker? All right, seeing none. So next up, we will be joined by Teresa Cobelt. She's the Director of Strategy, Innovation, and Forecasting for the Office of Policy at Ocali. Take it away, Teresa.
Thanks, Kelsey. I want to just thank you all for the opportunity to be here today and for your listening and all the work that you've done up to this point. Ocali was actually created in statute in Ohio to be a clearinghouse for all things related to autism and what we call low incidence disability. We work with a lot of state partners, various state agencies. We facilitate the interagency work group on autism and a number of other activities. You may wonder why we would be here today on a minority health strike force meeting. If disability was recognized as a minority population, it would actually be the largest minority population in the country, in the world. It is not currently recognized, but we know that disability does not care whether you are Black, white, young, old, Republican, or Democrat. It cuts across all socioeconomic factors. What is important to us in this conversation is that people of color represent huge portions of the health and human service workforce. Steve, if you could go to the next slide, thanks. So when I looked through the interim report of the strike force, there were several things that stood out to me. And what you'll hear me talk most about today is the second one, this idea of evaluating and documenting the impact of the disease. And to be clear, the impact of COVID-19. As I looked at the report and I realized it was written at a point in time, what struck me is that so much of the report was about preventing the disease, about resurgence of the disease, about testing and screening. And I feel like we're at a point in Ohio where much of the rest of the state is beginning to talk about what recovery looks like, both from an economic standpoint as well as a health standpoint. And what I would really like to see talked about among this group in the strike force is what short and long-term impacts are. What kind of data and research do we have around those long-term impacts, particularly in areas of social determinants of health? And so I'm wondering, are minorities recovering in every sense of the word? And you'll see, again, our particular interest or tie to this conversation, aside from just being Ohio citizens. If you could go to the next slide, Steve. The direct care workforce obviously is particularly important to our constituents. Women of color, you heard some of these stats before, make up the largest and the fastest growing segment of direct care workforce. So not only do they make significant contributions, they're also just at greater risk because of where they work. The poverty rate for women of color in direct care is higher than any other group, and 49% of women of color in direct care rely on public assistance. Another area that we have specific interest in is the area of early care. Many of Ohio's youth are at risk of or have developmental delays. And again, women of color, people of color are far greater, are great contributors to that workforce. Nearly 40% of early care workers are people of color. I think this is important to note. This is dramatically different than what we see in K through 12 education, where 80% of teachers are white. I think this is a really important conversation thing to note in terms of where we're putting priorities, and are we focusing more on a workforce that's 80% white? Are we taking into account the 40%, the other workforce where 40% of early care workers are people of color? Another important thing to note is that in center-based early care, early educators are more likely to earn less. Again, we saw some of these statistics in terms of earning before. I think what hasn't been mentioned yet, that's even after controlling for educational attainment. So some of those other statistics I'm not as familiar with, but this is even when we look at, does that mean because someone had a bachelor's degree or a master's degree, even when we control for that, African-American workers earn less than white workers. And then just in general, here's a slide or a graph that I stole from another location. We talked earlier about just Black workers in frontline jobs. These are all jobs that largely benefit Ohio as a whole, specifically some that benefit people with disabilities. You'll see on the next slide, another thing that I think is really important that we haven't talked about yet is that Black workers are, this is a direct quote from another source, but less able to weather such a storm because they have fewer earners in the family, lower incomes, and lower liquid wealth, as mentioned before. They also are not typically in jobs that have had the ability to stay or work from home. The last slide, public transit was on there, and that's a perfect example. If you are a COTA bus operator, you didn't have the opportunity to work from home. Many of those frontline workers did not have that opportunity. Also important to note is not only, if you could just go back to that one again, I want to just point out the difference as we look at data between unemployment and employment participation. I think this will be something that's important for the strike force to look at and consider going forward. As of April, that first bullet point, less than half of the adult Black population was employed. And this again is different than just looking at unemployment statistics, but who is actually in the workforce, participating in the workforce, not just who has been unemployed. Next slide. So a couple things, again, as I looked through the report, the things that were occurring to me that struck us from our perspective, which I want to note is I am a white woman. The research and data that I look at is largely gathered, as is most data and research, largely gathered by white people, reported in publications, largely reviewed by white people. So I think one of the strengths that I saw throughout the report was this idea of working with communities of color for outreach efforts. I would also add to that working with communities of color to figure out what does recovery mean or look like to them. And so some of those recommendations, things that I mentioned, just recognizing the contributions of minorities to frontline industries when you're looking at reporting both on unemployment, reemployment, and then just employment participation. I think those are also key areas that you could leverage those work sites for some of the other efforts in terms of screening, testing, education, gathering input from those specific industries and the workers within them. And then similarly, this administration has talked a lot about social determinants of health, and that is to be applauded. And I think it is the exact thing that needs to be talked about or continue to be talked about within this conversation. So what impacts have short-term and long-term impacts have minorities experienced because of not being able to access employment, not being able to access programs and services that directly tie to social determinants of health. Yep, time.
Time's up.
Yep, that's it. That's the last slide. So.
Thanks, Teresa. Any questions for Teresa? We have been getting a few into the chat box. So if we have questions from the strike force for Teresa first, and we will move to a few of those. All right, so this is one for members of the strike force and presenters, if you would like to weigh in as well, I think that'd be great. We have, is it true that more time and resources are invested in collecting and analyzing data rather than in implementing real meaningful change? Or would you feel that more time is spent collecting data than acting on it?
It certainly feels that way, particularly I think for a community that feels like it's been to the extent it's been visible at all, it's been visible in ways that have not been about implementing a positive change. So that, you know, as a public health person, one of the things that we learn in public health school is if you're going to go and study people, you know, make sure you figure out what you're bringing to them, right? This is not a take, let me get your information, let me get your research, let me get your data. Where do we contribute back? And I think that we hear this frustration when we go to communities of color and say, we want to collect your data. And they say, well, you've collected a lot of data up to now. What are you doing with it? And I think that that's a really understandable frustration, and one that it doesn't mean that we need to collect less data, because we really do need that information to make good informed choices, often because our implicit biases lead us down the wrong paths. But at the same time, to short shrift implementation does a tremendous disservice, and also I think leads to less trust of people who claim to be prepared to help.
Thanks, Maria. Anyone else like to weigh in? Thank you.
Okay, only other quick comment, Kelsey, is just what I have seen and what I'm sensitive to for the strike force members in particular is that you will have to make a case for prioritization. There will be limited resources and limited dollars. And so while I don't know the answer to whether more resources are invested in collecting and analyzing, I do know that when you have to make a case for something, right, wrong, or other, it is currently the way cases are made. And so with that,
I'll just add, I'm Dina Chisholm, and I am a faculty member in pediatrics and public health at The Ohio State University. I think that the question about how resources are spent is not fully clear because there's a lot of money spent in a lot of corners of the world. And I think, you know, the response is mostly about how government dollars are spent, and is the government spending more dollars on collecting and analyzing data than they are on implementing programs, and that may be true. But if we looked at all the time, energy, and money that's spent in communities on community programs by churches and community organizations and individuals who are making a difference, it's a lot. We don't calculate it, we don't quantify it, because it's not systemic. It is true community grassroots level work. And I think that we don't give that its proper value when we say money isn't being spent on it because the government isn't the one spending money on it. I think as a public citizen, I would say that the government's money isn't always the best money to spend in the right places because their priorities aren't always the same as the priorities of the people on the ground. So I think that there's value when you ask a question about how money is being spent, that we think about the dollar more broadly than the government dollar.
Thank you, Dr. Chisholm.
This is Angie Dawson.
Please go ahead, Director.
This is Angie Dawson. Certainly the commission has continued to bring light to the cost of health disparities. So when we look at the cost of health disparities, and that is hovering right around $93 billion. So we have to decide, you know, what we allocate funds to and where we get a return on investment, so to speak. And so given the fact that health disparities continues to cost this country so much money, whether that is in hospital care, emergency room care, and you all, I know, have read the reports from HPIO and Ohio standing in terms of 46 in the nation for health value. And so I just think that it's important that we also consider the cost of what we choose not to do or what we choose to do.
Thank you for that, Director. We will go ahead and move on to our next presenter. We'll be joined by Kelly Capitosto with the Kirwan Institute for the Study of Race and Ethnicity. Kelly, whenever you're ready.
Great. Thank you so much for having me on today's call and inviting me into this conversation. It's also good to see some familiar faces and familiar names here on the call as well. So I don't have any slides. I'm a proud millennial, but sometimes you have to do it old school, so you're going to be looking at me. So again, I'm Kelly Capitosto. I am a senior data and policy specialist at the Kirwan Institute. Kirwan has been immersed in this data and equity space for a long time now, specifically having to do with health disparities. And we have a lot to cover in a short amount of time, but we're also in a present crisis that needs acknowledged. So I wanted to create some space of that. We're in the midst of COVID-19. We're in the midst of mass resistance towards racial inequity. And that's something that's incredibly heavy and traumatizing and can be particularly difficult for many on this call. So I think that that's just important to start out with and to acknowledge and hold space for that. And I think it's also important to acknowledge because it also offers a time of unique opportunity for groups like this that are oriented towards targeted change, especially speaking for those of us with white privilege and those of us, it's a time when our advocacy needs to be strongest and most informed by best practices. And Kirwan's lens has always been one that provides this type of information having to do with contemporary issues like COVID, like what we're experiencing in our communities. but also is very adamant about how we view data and policies through a historic lens. And that's been the value added for us as a research institution, and it's something that's particularly important for our conversation here today. So for those of us that are on the call today and that are not familiar with our institute, we're founded roughly 16 years ago as a research arm at OSU, particularly invested in racial equity and justice by using two different perspectives, that being the research arm, academic research, and community engagement, and blending those two lenses together. We understand that inequity persists through both in-person and systemic factors, meaning it can be everything from attitudes, beliefs, behaviors, biases, all the way to institutions, our laws, formal policies. These are all drivers and antecedents for the inequities that we're grappling with in the present. And for many of us, it literally just takes a step outside of our doorstep to see the tremendous amount of pain and sadness that has resulted from decades of disenfranchisement due to racism and inequitable policies. So when we talk about data, we have to talk about these antecedents, not just within the healthcare system, but beforehand as well. We have a lot of information about race and public health that we work on at Kerwin, particularly the experiences of Black and Latinx women, as others on this call have mentioned, looking on that intersection as well, just due to, in particular, higher instances of infant mortality, but looking on the social sciences side, both of these groups have some of the most adverse experiences with medical professionals, everything from pain not being acknowledged, and just general barriers of being viewed with dignity and the respect that they deserve in medical settings. And I wanted to just speak briefly to something that's personal to me, because we have conversations about data and we have conversations about metrics, but I think it's important to capture narratives that this data is actually trying to represent. These days, I've made it a practice to also come out as Latina, as well as white. And this is a story about my aunt who predominantly spoke Spanish. She received incredibly poor treatment while she was in the hospital for heart failure, was consistently mistreated by staff because they could not understand her accent, and just made fun of. And that was an incredible indignity to feel at such a vulnerable place and time. She knew the work that I did and continued to encourage me to fight for equity for others that experience these same experiences of discrimination. And that's something that I like to share because it continues to push me and challenge me in that work. But we know that pushing things forward, change happens in the aggregate. And it's all about capturing stories just like this one that can continue to push us forward and challenge us with what we do. So getting back to the data itself, some of the other speakers have talked about the continued importance of weaving in that economic lens and perspective. So I won't go into some of the information about wealth that I had prepared, just because I think that that's been covered really well. But looking at national SHED data, it's really important to understand how communities are dealing with sudden economic vulnerabilities or shocks. More than 60% of Hispanic and Black households do not have the savings or resources to cover an unexpected expense of $400, which is twice the rate of white households. And these figures matter because the most cited incidence of unexpected financial expenses comes in the form of medical fees or debt. And here locally, that's on the national level, but in Franklin County, people of color are 1.8 times more likely to have medical debt. So when we talk about data, I just think that it's important to contextualize it. Yes, we need to talk about the current crisis. Yes, we need more data relevant to the intersection of race and gender. But we also need to be very mindful of these considerations, such as economic perspectives, that already left Ohio residents completely vulnerable, even before the spotlight was on these concerns. So that's something that we care deeply about at Kerwin. Representation matters, of course, in the data, but also in conversations, speaking to this room of advocates and all the people that I respect here on this lineup. We need to continue to push ourselves to make sure, our panels, our conversations, our engagements are reflecting the diversity that we want to see. As Teresa and some of the other folks mentioned, usually when you talk about data and research spaces, there's a lot of white privilege in those rooms and a lot of white privilege in those spaces. And I think that we need to do better about being transparent about that and being honest about that. So today I'm just going to humbly end my time, wrap it up, just to call us into modeling this work through both data and through our engagements. Thank you to the group for including the Institute in this important space and conversation.
Great, thanks so much, Kelly. Any questions for Kelly? We will move to one of the questions we received from one of our attendees today. This is for members of the strike force as well as panelists if you'd like to weigh in. Does everyone envision a mixed race category and then a breakdown of that category? Several years ago, a mixed race became a more frequent choice for child welfare data specifically, and the Black category started to decline. This does not reflect progress in real life. We weren't wondering about the experiences of other systems.
So I think that, and this is coming as a health services researcher who is engaged in how we collect data in our hospital system. And I think that we are probably more moving towards a check all that apply than a mixed race data collection process, which allows us to understand the people's personal identities and how they report their own components of race. Some people who are mixed race really fully identify with one group. Some don't identify with any group. There's a lot of different ways that this is happening. Some people are saying sort of what's the race of your mother and what's the race of your father, not asking what your race is. And that way you're able to decide that. Or even going back to grandparent level. There's a lot of different ways to measure it. Some of the data that we have done, some of the research that I've done, particularly in pediatric mental health, has shown that youth who identify as mixed race have a whole different set of disparities and outcome challenges than those who report as Black or African American. So it's actually an increased risk. So understanding that that's not necessarily the same population is important. I think it's still a work in progress.
Thank you, Dr. Chisholm. Jody, did you have anything to add? Oh, Jody, sorry, we're having problems hearing you.
There we go. Can you hear me?
There we go.
Jeez,
Yes.
I've had nothing but technical issues this morning. I was just saying Dr. Chisholm's statements absolutely are concurrent in what happens in the behavioral health community. It's in terms of how people self-identify as they come in and they complete initial paperwork. I'm not sure a mixed category really fully helps people identify how they identify themselves.
Thank you, Jody. We'll move forward to our next presenter, joined by Franco Formicelli. He is the director of the United Way of Greater Cleveland's 211 Help Link, and today he is representing the Ohio Alliance of Information and Referral Systems. Franco, whenever you're ready.
Thank you. And again, I am Franco Formicelli, and I head up the 211 Help Link for United Way of Greater Cleveland. If you're not familiar with 211, I mean, it's an easy 3-digit number to remember that really connects individuals with agencies and resources in their communities to help with social service needs. Speaking today on behalf of the Alliance of Information and Referral Systems, which really oversees the 13 211 help links that are out throughout the state of Ohio. So I'm happy to join you today and share some data that we've pulled and can report out during this COVID-19 crisis. So prior to the pandemic, access to 211 was available for only 85% of Ohio's population, about 51 of the 88 counties. And again, in these counties, 211s were connecting people to the resources they need. And again, it's 24/7 service, 365 by phone, text, email, or chat. About the second week of March, the Ohio EMA reached out to Ohio Heirs and asked us if there's anything we can do for those 37 counties that do not have 211 service. And if you look at that, the image up there, those are the list of counties, the 37 counties that did not have 211 service in the beginning of March. So we quickly, I think it took us about a little over a couple of weeks, we're able to put 211 service and extend it out to these 37 counties. So there was 100% coverage for 211 for the state of Ohio for all 88 counties. So with that, we'll give you some data. So during the initial 4 weeks of the crisis, our 211 navigation specialists rose to the challenge, and we took about 90,000 Ohioans contacting us for basic needs. Overall, it was about a 43% increase in call volume in that 4-week period. The 4 weeks we're talking about is March 15th through April 14th. That was really where we saw the major hit as far as call volume as a result of the pandemic. Food by far was the most requested service. We saw a 132% increase in requests for food, food distributions and food banks, followed by clothing and personal household needs, which had a 33% increase. Rental and housing assistance, a 31% increase. And then, a few of the others were around income assistance, mental health and addiction services, healthcare, and utility and legal services. Again, many of these contacts were calling us for the first time, so they had no experience accessing social services. Obviously, as a result of the pandemic, a lot of people lost their jobs and were unemployed, so they were really reaching out for the first time. So we saw our call times go up, we saw our handle times go up, and then obviously, along with that, our hold times went up a little bit as well too. But again, we were able to get through about 90,000 individuals in that time frame. As far as what we track from a demographic perspective, we capture zip code, age, gender. We do not track race. However, we do know that the majority of our calls are from families and older adults with low incomes, particularly minorities and Medicaid enrollees. While the majority of 211s do not actually capture race, there are a couple that do, and one of them is a pretty good sized one, which is the United Way in Summit County. And they reported out that about 50% of their calls coming in were from minorities, and I would suspect that probably would translate to the other ones as well too. So we think about 211. Each 211 provider maintains a comprehensive database of social services available for our residents in their service area. I could speak to a way of Greater Cleveland, where we have about 4,500 agencies with over 20,000 services available locally in Cuyahoga County, Geauga County, and Medina County. So again, one of the big pluses and one of the most valuable pieces of 211s is just the information we've had and how robust our database is. These databases are actively updated, includes local, state, national nonprofit organizations, and government agencies. I can tell you in the first 3 weeks of the COVID-19 crisis, so around that same time frame, about mid-March, we made 7,000 updates to our database in my United Way. I mean, a lot of those, unfortunately, were services that were being shut down because volunteers couldn't get out and other things. But then a lot of it was adding stuff, different days, updating dates around food distributions and all that kind of stuff. So again, the importance of the database being timely and updated, because we don't want to send individuals to a resource. Sometimes people using their last dollars to get there and find it closed. So again, the importance of the database is there. Many 211s are highly involved in our local community responses. We were able to quickly work with local agenda and health departments to establish local COVID helplines and coordinate food delivery for individuals who were quarantined or at high risk during COVID-19. Under normal circumstances, people in need require assistance to navigate the complex social service safety net, and at times of crisis, the need is even greater. It's really across the country, 211 is playing a key role in response to COVID-19. In Ohio, 211s have been active part of disaster response and recovery during past disasters as well. A few of them to note was the response to tornadoes and mass shootings in the Dayton region in 2019. We've even with the algae bloom impact in Toledo in 2014. So on behalf of Ohio Heirs, we believe every Ohioan should have access to 211 service 24 hours a day, 7 days a week. It's unfortunate that those 37 counties lack sufficient resources on 211 in the community. And actually 9 of those 10 Ohio counties were the highest poverty rates among those without coverage. As 211s, our interest is to be a long-term partner with the state of Ohio and organizations in our local community in helping address health disparities. There's a considerable amount of data showing that the needs in our state. Considerable research has been conducted on 211s as far as partners to reach populations with health disparities. How conversation about food or housing can be used to talk to someone about health. We want to use every avenue, such as hold messaging, outreach, and even and mostly in-person engagement with people who are at high risk with their knowledge and health to use in preventive services to access the healthcare system.
Excuse me, Franco, time's up.
Sure.
Thank you so much, Franco. And just to draw attention to the strike force's attention there, Franco did provide written testimony as well, and this is recording, and we will of course provide a link to the full recording after the conclusion of the meeting. We do have one additional presenter for our town hall today, but Franco, we had one question come in to the chat. If you could answer very quickly, I'm sure there was a hold time for some of your organizations and in the counties. Was there what was the average hold time during peak call volume? Did you have an issue with capacity during the first?
So it took some centers ramped up pretty quickly and were able to address it. Like in Cleveland, we were able to address our call volume, and others weren't. I would say on average it was about 5 minutes. And actually, if you think about it, that was actually pretty good with the amount of with some call centers doubling in volume. And others, we even seen in certain centers triple in volume. So it's about 5 minutes before we can get to somebody and provide the resources.
Thanks, Franco. I think 5 minutes is a better track record than I'm sure the capacity some of our state agencies were experiencing. So I really appreciate that those services were available at the 211 line. So our final presenter for the day, please welcome Jody Long. She is the Associate Director at the Montgomery County Adams Board. Jody, please take it away.
Thank you. You can go ahead and move to the next slide. I appreciate having the opportunity to share and present here. As I listen to the other presenters, some of the challenges that we've seen are siloed data sets. It's not that we don't have data sets in Ohio or that we've not collect data sets around race. It's that they're siloed across our government systems, and often full access to those data sets impede the work at the ground level of those of us in our local communities. And so one of our recommendation is that we work with our alcohol, drug addiction, and mental health services boards at the state level to share all of those data sets from the Department of Medicaid that don't always come down to the local level to the ADAMIS boards, as well as the managed care organizations. We have a wealth of data, but again, accessing it is our challenge, and then it cannot always be used. So the data that we do have is what we frame on and what we build on initiatives, but we know from the very get-go that we're lacking the full data sets. And so that would be tremendously helpful. And when I talk about data sets, I'm talking about hospital data sets, EMS data sets that the Department of Health collects, not only the Medicaid data sets. And there are ways to share that. And I think with HIPAA, people think we can't share it, but there really are creative opportunities to share that when we work together and put together the necessary pieces. Next slide, please. The other piece that we're seeing in terms of research and data and how it impacts it is utilizing that data to develop technology to deploy it out to our frontline workers, whether they're our outreach workers, our community health workers, our quick response teams in response to the opiate epidemic. Those are all becoming critical so that boots on the ground can respond to areas of or hotspots in the community that are experiencing a rise. Locally, some of the things that we've done, we've worked with our hospital systems to utilize emergency room overdose notifications so we can get that information out to our community health workers within 24 hours so they can do follow-up and reach people in the community. It is possible to share these data sets. Sharing with the criminal justice system. We, in Montgomery County, the ADAMIS board gets all of the jail admissions every morning, and we cross-reference that with the data sets of people who have had treatment. So we can send notifications out to the treatment agency saying, your client touched the jail last night. Can you please follow up with the jail or reach out to the individual if they've been bonded out? That becomes critical. When you think about stigma and how we do outreach, we very much had to face in Montgomery County when we have some of the highest opiate overdose numbers. That's pretty well known. But there was a lot of anger from our African American partners in the community that the amount of response and effort and planning to respond to the opiate epidemic, while justified for the individuals impacted, was not the response when we saw cocaine and crack hit the African American community. And we have to work through that and utilize the data sets and have those conversations openly and apologize when necessary to say, you're right. You know, in the 80s and 90s, we incarcerated drug addiction. We did not treat it. And then now our efforts are, how do we maintain what we've built in terms of responding, particularly to the issues of addiction, for the next drug of choice, so that the drug of choice doesn't become a point of racial discrimination. And so if you have a drug of choice of opiates that affects particularly white males, you have one response in the criminal justice and treatment system. And if it's a drug of choice of a minority population, there's another response. That is not equitable. It does not create social justice at all. And so gathering those tools and making sure that they're accurate becomes critical to us moving forward in behavioral health. Stigma is an issue with people seeking behavioral health treatment altogether, but particularly for minority populations, they walk into community behavioral health agencies and they look around and they say, is there anyone that I think understands or looks like me or has had a similar journey to me? And the fact is no. Predominantly, the behavioral health system looks a lot like me, Caucasian, white woman, because people have been encouraged not to go into social work in the chemical dependency fields. They've been told that it's not a way to create a career or a life or a job. And so there's not people of color. It's not equitable. Our workforce is not equitable to our demographics. It's not equitable to our communities. And that's definitely a piece that we continue to address. Next slide, please. In terms of some more specific things around the COVID crisis, when the dashboards were created by ODH for the dashboards, they are wonderful. But in the very that's my timer. In the very beginning, individuals facing behavioral health challenges were not included in those dashboard indicators. So when they talked about congregate living settings, they talked about homeless shelters, they talked about nursing homes, they didn't talk about the adult care facilities that house people with severe and persistent mental illness, nor the recovery houses. And I realize my time is up.
Jody, thank you so much for your presentation. Any questions for Jody specifically? And we do understand and recognize we are a few minutes over our scheduled time today. We understand if you have to step away for additional obligations, but please know, again, this is a town hall forum. We have a couple questions just in the queue to cover before we sign off today. So we appreciate your time if you are welcome or able, and you are welcome to stay. So first, any questions for Jody? All right, well, we will first go to the two we have in the queue. First is for any panelist. This says, as a state and a nation, we are finally exploring the health impacts on the African American community. Can any of you address any health disparities on our Asian American population?
Stigma is a huge issue. Prior to working in Montgomery County for 5 years, I worked in Miami County. And because of some auto industry, we have a large Asian community. Stigma to seek behavioral health services culturally certainly is a barrier that continually is addressed.
Thank you, Jody. And a final question today. Can anyone share how their organization or system has used a participatory research model that included populations of color in collecting and reporting data? Well, we will think on that, and possibly if we get a response, we'll be sure to include it in our follow-up information. And I just wanted to thank you so much. Marie, did you have something you wanted to add? Great. All right. I wanted to thank you for your time and attention today, especially to our panelists and the members of the Minority Health Strike Force that were able to join us this morning. I wanted to give you a preview that there will be another town hall later today at 4 p.m. This will feature the Education and Outreach Subcommittee of the Minority Health Strike Force, so make sure you sign up for that if you're able to. We will be following up again with contact information from our panelists, the slides, as well as the full recording of our conversation today in a follow-up just this afternoon. So please watch your inboxes and please feel free to share that with any of your networks. And we encourage you to continue to take part of these conversations, and we are happy to provide this platform today. So feel free to reach out to me with any questions, and please enjoy the rest of your day and weekend. Thank you again, everyone.
Thank you again for the opportunity.
You're welcome, Marie. Thanks for joining. Thanks, Franco. Thank you.